Hello everyone. In this episode of Learning Pharmacology, I shall discuss presynaptic receptors and presynaptic regulation and its clinical relevance. The target audience is primarily postgraduates in the pharmacology. There are two terms which are used: regulation, that is receptor regulation, and receptor modulation. Regulation means keeping the receptor activity within a narrow range as needed for optimal function. For example, physiological function. The range is narrow. Blood pressure regulation, regulation of hormonal secretion, blood sugar or blood glucose regulation are the examples. In the same way, there is always a regulation of sympathetic tone under normal conditions. Modulation means modifying activity according to the needs created by external factors, and sometimes the variations are beyond physiological ranges. Examples of modulation in body are neuromodulation, pain modulation, selective estrogen receptor modulators. That means these drugs modulate the receptors. Some activate, some inhibit. Immunomodulators, most importantly, relevant here is allosteric modulation, autocrine and paracrine modulation of transmitter release. The modulation may result in measured increase or decreased transmitter release and is used interchangeably with receptor regulation often. Here I will focus only as now pre-synaptic receptors are located in the ganglion, in the spinal cord, in the brain, and as we all know, the brain contains polysynaptic connections, and presynaptic receptors are located at many places including interneurons that secrete an amazingly efficient regulation of neurotransmitter release exists by this presynaptic mechanism, and presynaptic mechanism in fact include transporters and receptors. I will not discuss transporters presynaptic mechanism. I will only discuss presynaptic receptors as the regulators or modulators. And it is known that there is abundance of the presynaptic adrenergic cholinergic receptors in autonomic nervous system, peripheral nervous system, and in the brain, and the receptor density varies depending on the location and the type of the receptor. For example, dopamine receptors will be located in certain areas, whereas serotonin receptors will also be located densely in other areas. Among the existing subtypes, selective and non-selective drugs, there are few preferentially acting presynaptic receptor active drugs, and that specificity and selectivity determines the therapeutic utility of such drugs. Now, presynaptic receptors, as we all know today, are two types: autoreceptors, also known as homoreceptors or homotropic, causing homotropic regulation, and heteroreceptors, causing heterotropic regulation. Now, autoreceptors are located on or close to the axonal terminus of a neuron, through which the neuron's own transmitter activity is modified depending on the input from the postsynaptic level of the transmitter. So adrenergic system, cholinergic system, and systems in the brain all have autoreceptor regulation. Examples are nicotinic acetylcholine receptors, autoreceptors, and they enhance the release of acetylcholine. Noradrenaline release from the sympathetic neurons also inhibits its own release by activating presynaptic alpha-2 and alpha-2C receptors. Serotoninergic autoreceptors mainly are considered 1B and 1D type, and they reduce the central level of serotonin in the synaptic clefts. Presynaptic beta 2 receptors enhance noradrenaline release, indicating they are stimulatory, whereas presynaptic GABA B receptors function as autoreceptors but inhibitory. So there are few examples which show that presynaptic autoreceptors are in the central neuroaxis. Now pictorial will show how there is heterotropic presynaptic regulation. Acetylcholine may not only give input to presynaptic M2 receptor, but it will also have modifying action on the alpha 2 A receptors, and thereby there is an interchange, that is adrenergic system alters or regulates cholinergic activity and cholinergic system regulates adrenergic activity, and this is clearly seen in many organs and brain. In heart, noradrenaline inhibits acetylcholine release and acetylcholine inhibits noradrenaline release by such heterotropic regulation, and this is very commonly seen at many different subtypes of nicotinic cholinergic receptors may also act as heterotropic receptors, although they are homotropic homotropic receptors. Now, for example, A7 variety of the nicotinic receptor regulates glutamatergic activity. Similarly, alpha 4 beta 2 subtype of the receptor controls dopaminergic activity. So, this such heterotropic cholinergic receptor is widely known. The tables below would show you the nature of homotropic or heterotropic receptor, but both of them are inhibitory. Noradrenaline, dopamine, serotonin, ATP, ADP, adenosine, histamine, enkephalin, prostaglandin E1, E2, and neuropeptide Y. Through their specific receptors, they either act as autoreceptor inhibitory or heteroreceptor inhibitory. In the same token, there are excitatory responses, whether autoreceptor or heteroreceptor, for adrenaline, angiotensin II, and acetylcholine. And the acetylcholine is shown in the upper table that it acts inhibition of its own release as an autotropic inhibition, but also inhibition of the activity of other transmitters. They can be called as co-transmitters, whether it is inhibitory or facilitated. For example, it facilitates release of glutamate, GABA, 5-HT, and dopamine, whereas it facilitates release of its own acetylcholine in the many areas, particularly in neuro. Now, type of the receptors involved in presynaptic mechanisms are adrenergic. Most important is alpha 2, particularly alpha 2A and alpha 2C. Alpha 2B are mostly postsynaptic. Beta 1, beta 2, dopamine 1, dopamine 2. Of these, dopamine 2 are mostly both types, postsynaptic as well as presynaptic in the brain. Particularly subvariety of dopamine, that is D2S, play key role in presynaptic mechanisms in the striatal limbic system, thalamus, pituitary, and hypothalamus, and may act as autoreceptor inhibitor, inhibition of transmitter release, reducing adrenal cyclase activity, or may also inhibit the noradrenal release. May also modulate GABAergic, cholinergic, glutamatergic. Serotonin 1B, 1A, 1D. Among them, 1B and 1A are important. Even now, it has been increasingly realized that 5-HT2 variety of receptors are not only postsynaptic but also presynaptic thalamocortical projections, which serve important modulatory function. The cannabinoid CB1 receptors they bind endocannabinoids and they have heterotropic inhibition of co-transmitters. Similarly, adenosine, ATP, glutamate Receptors mGlu1 and mGlu5 particularly and GABA B subtypes are involved in presynaptic regulation, and their underlying mechanisms and subcellular events vary depending on increased potassium permeability and reduced calcium. Now, what is the clinical relevance? Although it is an important pharmacological activity, but there is a great clinical evidence. It has been found that presynaptic vesicular dysfunction is more intensely researched, and it has been found that many neuropsychiatric and degenerative disorders are characterized by presynaptic dysfunction involving vesicular cycle. But presynaptic modulation of receptors activity has been less intensely worked out, although there is some evidence that such receptor dysfunction exists. Presynaptic AMPA receptors have unique position in that they are double type of the receptors, ionotropic, metabotropic features having, and this is involves in the local regulation of actin dynamics in both dendritic and axonal departments. Obviously, such activities affect the neuronal plasticity. And there is evidence that suggests a key role of presynaptic AMPA receptor regulation of the pain transmission and in the physiology of auditory system. Drugs are being developed depending on their binding abilities on the AMPA presynaptic receptor. More examples which are known are NPY presynaptic receptor can modify its own release and that of other transmitters via presynaptic Y2 receptors. Presynaptic opioid receptors inhibit release of substance P as a heteroreceptor and other neurotransmitters from primary afferents in the spinal cord. Mu opioid receptors agonists act presynaptically on small high threshold primary afferent C fibers to block opening of the voltage sensitive calcium channels, therefore prevent transmitter release. Mu opioid also act as agonist presynaptically on dopaminergic releasing terminals as heteroreceptors to inhibit transmitter release, and this probably accounts for enhanced prolactin secretion. CB1 receptors are found in central GABAergic interneuron and act as retrograde messengers here. This is a unique property of CB1 receptors and endocannabinoids. They are involved in synaptic plasticity and neurotic. ST receptor presynaptic activity in the brain. They are autoreceptors, so tonically reduce histamine release. They are also heteroreceptor, therefore modify release of many co-transmitters and monoamines, and as the receptors have high constitutional activity and therefore inverse agonists which act as actually antagonists functionally increase histamine release from these neurons. And currently a selective S3 antagonist, pitolisant, which is high S3 receptor binding, has been shown to be effective in the treatment of narcolepsy, daytime sleeping due to obstructive sleep apnea syndrome. Now, we also observe unique clinical phenomena with presynaptic regulation. Atropine in small doses causes bradycardia. Instead of tachycardia, the dose less than 0.5 mg causes bradycardia, and this is attributed to the M1 receptors located on parasympathetic presynaptic receptors in the SA node, which normally inhibit acetylcholine release. Because of their inhibition, there is greater acetylcholine release. A difference between tiotropium and ipratropium as bronchodilator is because of presynaptic regulation. It is found that tiotropium is more selective in inhibiting M1 and M3 receptors in the lungs. M1 are presynaptic. Ipratropium is somewhat less selective and can inhibit presynaptic M2 receptors in the lung, so may antagonize its own bronchodilatory action. Many other examples are there, and phenomena can be explained. Antihypertensive action of non-selective beta blocker is partly explained by its ability to block presynaptic beta receptor that normally enhance orbital release. So there is a reduce the noradrenaline release, causing fall in blood pressure. Methylxanthines have positive chronotropic and inotropic on the heart. The effect is attributed to increase in cyclic AMP directly because of inhibition of PDE enzyme. However, it has also been found that in low concentration, this effect may be result from inhibition of presynaptic adenosine receptor in the sympathetic nerves, thereby increasing catecholamine release and nerve ending that causes the cardiac stimulation. Varenicline is used as an aid to smoking cessation, is a partial agonist on the presynaptic nicotinic subtype receptor and a full agonist at alpha 1 subtype receptor, and both are located presynaptically as well as postsynaptically. And it has been shown that persistent antagonistic activity due to partial agonist activity is does not allow the nicotine to bind because there is a greater binding of the varenicline, and this prevents the craving, that is a stimulant effect of. Tetanic fate seen with competitive neuromuscular blocker can be attributed to presynaptic autoreceptors. Non-depolarizing blocking drugs block facilitatory presynaptic autoreceptors and thus inhibit the release of acetylcholine during repetitive stimulation of the motor nerve, resulting in what is known as tetanic fit. It will not be seen with non-competitive blockers. Sumatriptan is used in migraine because it activates 5-HT-A, particularly 1D and 1B autoreceptors to reduce neuroinflammation. Although there is also additional mechanism through 5-HT1 receptors located presynaptically to reduce release of calcitonin gene-related protein. Procalcipride is used in irritable bowel syndrome, predominantly constipation, because it stimulates enteric ganglion presynaptic 5-HT1A autoreceptors that reduce the acetylcholine release. Tigaserod being 5-HT4 partial agonist and procalcipride also being a partial agonist may actually increase colonic activity, so they are used in this disease. Tigaserod, because of cardiovascular adverse effects, is not much used. Levodopa adverse drug reactions, disorders of impulse control, gambling has been found with continuous use of levodopa in about 45% of patients, and this is attributed to activation of presynaptic D2 receptors in the mesocortical limb. Clonidine is well known to cause fall in blood pressure due to central presynaptic alpha 2 C or A receptor inhibition. In addition, it may also reduce activity or modulate activity of co-transmitters. Tizanidine specifically acts as an agonist in the spinal alpha 2 receptors, and therefore it increases presynaptic alpha 2 inhibition of motor neuron. Dexmedetomidine is well known to activate central alpha 2A receptors, which are presynaptic, and therefore is used for short-term sedation analgesia during intervention and anesthesia as an adjuvant to anesthesia because it causes minimal respiratory depression. Apraclonidine, brimonidine are used in the treatment of raised intraocular tension. The mechanism of action of alpha-methyl-dopa has been attributed to presynaptic alpha-2 receptor inhibition in the activation in the brainstem like clonidine. Intraspinal adrenaline produces analgesia and can be used as an adjuvant because it stimulates alpha-2A receptors, reducing nociceptive transmission upward. Phenoxybenzamine causes cardiac stimulation by blocking inhibitory presynaptic alpha-2. Presynaptic beta 2 receptors are used in asthma, and one of the contributory mechanisms is that a presynaptic heterotropic activity is there. Reduction in the neurotransmitter release in human airway cholinergic nerves by an action at the presynaptic beta 2 receptors on the cholinergic neurons. This reduces acetylcholine that contributes to bronchodilator activity. Propranolol used in essential tremor. While most of the beta-2 receptors are aggregated in the muscle membrane, prejunctional muscle may also be found prejunctionally, and they stimulatory in noradrenaline release. Therefore, salbutamol action causing tremor can be explained by the presynaptic enhancement of the discharge for muscle spindles and use of propranolol because of beta-2 blocking activity in the treatment of essential trauma. Although metoprolol has also been found. Now, presynaptic regulation of monoaminergic system receptors in psychiatry is extensively studied, and it has been found that dopaminergic D2 receptor antagonism is the key factor in antipsychotic action, and when blockage is 60% to 75%, there is antipsychotic action, and when blockage is 80% and more in nigrostriatal pathway, there will be extrapyramidal reactions. There are atypical antipsychotics with low affinity for D2 receptors, olanzapine, quetiapine, and risperidone. Quetiapine work by decreasing 5-HT release. Less EPS is seen with such drugs like olanzapine and risperidone. This is because of their peculiar effect on the dopaminergic and serotoninergic system. Atypical antipsychotics have better control of positive symptoms due to combined effect on D2 receptor and 5-HT2A receptors as antagonist, and there is a control of negative symptoms also because of activity on the 5-HT2A receptors. Here they act, for example, pimavanserin acts as an inverse agonist at 5-HT2A receptors without any D2 activity, and this also benefits on the complex striatal adenosine dopaminergic presynaptic interaction. Although it has been discussed earlier, but here the focus is that many of the neurons, corticostriatal neurons, have presynaptic heterodimers between adenosine receptors and between adenosine and cannabinoid receptors, and these heterodimers play a role in mediation of presynaptic regulation, changing the signaling activity in D2 pathways, and that means there is a heterotropic regulation. In fact, stradifylin, which is a caffeine analog, is used as a postsynaptic striatal adenosine receptor antagonist in the Parkinsonism, and an investigational drug SCH442416 is being investigated as a presynaptic adenosine receptor antagonist in neuropsychiatric disorders, particularly so long as antidepressants are concerned. Trazodone, nafazodone, and mirtazapine have some presynaptic receptor modulating activity responsible for characteristic antidepressant. Complex mechanism of antidepressant effect of ketamine, and this involves presynaptic interneurons and receptors. The complex clear ketamine inhibits interneuronal NMDA that in turn changes the activity of GABA A receptor. That is, this inhibition results in greater release of the glutamine in the synaptic pathway that activates the AMPK transmission, and one of the effect is ionic entry through calcium channels, activation of mTOR, and increased protein synthesis, all responsible for anti So, in nutshell, to summarize, presynaptic receptors play a key role in manifestations of the autoinhibition or heterotropic inhibition in central neuraxis and peripheral nervous system. The autoreceptors can be ionotropic, metabotropic. Heteroreceptors can also be ionotropic, metabotropic, and they can be inhibitory or excitatory. To remember, autotropic receptors means homoreceptors or autoreceptors are mostly inhibitory, whereas both excitatory and inhibitory heteroreceptor activity can. Happy learning. To access more information on such topics, you may visit the YouTube site. Thank you.